It's my pleasure to now introduce Dr. Josh Levenson. He's the director, the UPMC Center for Cardio-Oncology, as well as the co-director for non-invasive cardiology here at UPMC Shadyside Hospital. He's an expert in imaging and is going to be talking to us about bicuspid aortic valve. What is the fuss all about?
Well, it's a great pleasure to discuss one of my favorite topics, the bicuspid aortic valve. I'd like to really spend the next maybe 10 minutes giving an overview of just the pathobiology of the bicuspid aortic valve, understanding a little bit about all of the different types of imaging modalities that we can use to understand and find bicuspid aortic valves, and a little bit about surgical indications, although coming from a physician rather than a surgeon, we'll see. So, thank you. While we start off the talk, I want to take a minute and just think about for a moment, what is the functional goal of the aortic valve? And just to break it down, number one, we need to allow the left ventricle to push blood out. Two is direct that blood into, I think, the center of the aorta. Three, I'm a cardiologist, so I have to think about the coronary arteries and allow blood flow to go backwards into the sinus and then direct it into the coronary arteries. And then lastly, prevent that blood from returning all the way back into the left ventricle. And obviously, if the valve is misshapen for some reason, a number of these different standard functions may become pathologic. Now, to start with the bicuspid aortic valve, we've already heard about a number of different pathologies of the aorta, but I think many would consider the bicuspid aortic valve the most common congenital cardiovascular anomaly. Some of our ACHD colleagues may disagree with that, but we'll see. There is a male predominance, but commonly seen in women as well, and there is an autosomal dominant inheritance of this disease, but the penetrance is quite variable, and so while it can run in families, we don't always see it. I think much of what we know about the bicuspid aortic valve really came from autopsy studies, and now obviously we have imaging modalities that allow us to learn about the valve before obviously death, which is what we're preventing. But I think we've learned a lot about what the complications are, and I think we know these commonly: aortic stenosis, aortic insufficiency, aortic aneurysms, and obviously complications of aneurysms like dissections. And the classic model for aortic stenosis was actually probably in the aortic bicuspid phenotype, which you'll think about from our standard Brown-Wald diagram from probably 50 years ago, which was really in patients who were under the age of 60 who had severe aortic stenosis. And so this is really the standard reason for patients who are under 60 to need a valve replacement. The aortic valve is most commonly imaged in our world with the adult population with echocardiogram, transthoracic echocardiogram, and I think this is a nice normal aortic valve with a little bit of lag here, sorry about that, but I think what you'll see is 3 leaflets with nice cusps that have separation, and if we pause it at any point, you'll be able to see a standard Mercedes-Benz sign that is representative of a normal tri-leaflet aortic valve. And when we think about the bicuspid patient population, there are a number of different ways we can see bicuspid aortic valves. And I think the standard Sievers classification is probably what we think about from autopsy studies and now have sort of a number of different ways we define it, but I think the Sievers classification is quite helpful. First is to think about whether there are truly only 2 leaflets or whether there are 3 leaflets and 2 of these have fused or more. And so a standard type 0 Sievers classification only has 2 leaflets. And if you look as the valve is open at the bottom of the screen in a type 0, there's really only 2 leaflets there. Whereas in a type 1 bicuspid valve, there are actually 3 leaflets, but 2 of them can be fused with a standard raphe. And it can look like 2 leaflets when in fact there are truly 3 there. It's just functionally bicuspid. You can actually have multiple different leaflet raphe such that there's a very narrow orifice. And there are other different types of aortic pathologies such as quadricuspid valve or a unicuspid valve that are some variants of this classification. This diagram, I think, may show it a little bit better and thinking about different types of raphe where you have fusion of the leaflets between the left and the right coronary cusp, or the right and the non-coronary cusp, or a non and a left. But I think the classic or the true bicuspid aortic valve is this type 0 leaflet pathology seen at the end of this screen here. This seems quite straightforward, but I think it's not always straightforward. And the most common way I think we will diagnose it is with echocardiogram. And so I wanted to run through an example of the challenges, I think, of finding a bicuspid aortic valve so we can really learn from it. This is a standard parasternal long axis view of the aortic valve, and then a short axis view of the aortic valve. And without color on board, the aortic valve has some degree of asymmetry, but aside from thickening, I'm not sure that anyone can clearly tell that it's a bicuspid aortic valve or not. But this is actually a quite severely diseased bicuspid aortic valve in a patient who's been known to have a bicuspid. And so if someone is asked to look at an aortic valve on echo and they know they're looking for a bicuspid, it's often easy to then call it. But from this patient who I know well, I was not sure whether this was a type 0 or a type 1 bicuspid valve, and often we will stare at these valves for a long time trying to decide which type it is. When you add color, I think we'll be able to see that this is a very diseased valve, and this valve actually has severe eccentric aortic insufficiency. You can see it's actually regurgitating all the way back into the anterior mitral leaflet, and can really tell also in an apical view that there's major flow turbulence. I haven't even mentioned the aorta here in the last few minutes because often we're so focused on the aortic valve we don't even think about the aorta. But I think what you'll notice is that there's major flow turbulence at the valve level. And if you go back to what the standard function of the aortic valve is to let the blood flow out and prevent it to go back. And as we think about this valve, for example, often it's hard to tell on a standard transthoracic echocardiogram what's going on with the aorta or what's going on with the aortic root. And we commonly rely on transthoracic imaging to manage these patients. And so I want to show you this example of the same patient who the next day we did a transesophageal echocardiogram. So let's just show you the value of more enhanced imaging and what it can really show you. And this patient has clearly severe aortic insufficiency that's quite severe, but it's been eccentric and actually has been going on for probably a year or longer and was previously called moderate. And so often without the keen eye to look for this, we can miss severe pathology. Despite being a transesophageal echocardiogram, it was not clear to me at this time whether this was a type 0 or a type 1, whether there's a raphe or not. I think there is, but I'll be honest, when I called this, I called it a type 0, and I was not sure. And commonly, it's very tough to tell until obviously at open surgery. But there is major value, and I think I'm excited to have followed a CT an MRI radiologist to really emphasize that when it's not clear, CT and MRI can really help define pathology here. And this same patient who had a 4D cine image of the aorta was able to really demonstrate, one, that there was a major aortic aneurysm, and two, that this was actually a type 1 bicuspid aortic valve, and that there's obviously enough pathology here to proceed with aortic replacement. This is a very common scenario where transthoracic echo shows pathology, but the exact severity is not known, and I think we should rely on advanced imaging when we need to. Aortopathy in referral centers can actually be as high as 40% prevalence for patients with bicuspid valve. And the dilatation, as you will see, can occur at the aortic root level, in the tubular ascending aorta, at the arch, or some combination of these. But I think mostly we're commonly seeing at a roughly 20% incidence if you look at the spectrum. In a standard CT, we can commonly see that the aorta is very well imaged, but we commonly will rely on just a transthoracic echo to look at the aorta. And I want to show these two pictures of that same patient who had both a CT and an echo to show that we can see the descending aorta and a little bit of the arch, but we're missing the majority of the arch and the ascending aorta on a standard transthoracic echo. And so please beware of that major pitfall. As we described, aortic dilatation patterns can be variable, and the question is always, why does this occur? Having heard from a geneticist, one of the questions is, why do we even have bicuspid valves at all? And clearly there is some genetic predisposition. There is a major theory here that extracellular matrix is the problem. The problem with that is that when we look for clear correlation between extracellular matrix genes and the bicuspid aortic aortopathy, they don't correlate. But there's clearly disruption of the elastin and collagen and smooth muscle loss in aortopathy with bicuspid aortic valves. And so I think the major theory is actually more of a functional concept, that when the valve has pathology, the blood flow is directed against the aorta in a pathologic way. And if you look actually at 4D MRIs, which were mentioned, you can see disruption of the flow patterns of the aorta. Here you can see a normal flow pattern, but in a patient with a not severely stenotic, but just abnormal directional flow of a bicuspid aortic valve, that blood flow is directly hitting the very proximal portion of the aorta, and over time that can really predict major aortopathy. In a different patient where the right and non-coronary cusp has RAF-A, that blood flow is directed in a completely different place. So I think functional MRI and just thinking about this concept when we're evaluating the patterns, even on echo, will really help determine what you think of the risk of the aortopathy is. So briefly, we commonly will look for aortic valves on imaging, and as described, if a patient has a first-degree relative with a bicuspid aortic valve, guidelines recommend screening because this can be inherited. But inheritance is obviously not a one-to-one correlation, but the aortic valve will really show it on imaging. If an echo shows or other imaging show that the aortic sinus is dilated, those patients should be followed with imaging, probably annually, and I think our discussion will probably talk about how frequently after that we should be doing. If the aorta really is not dilating over time on annual echoes, you could stretch out the frequency. And if we can't really tell what is going on with the aorta, a CT or an MRI is really recommended to help get standard aortic measurements. Lastly, in patients with bicuspid aortic valve, if there is an associated thoracic aortic aneurysm over 5.5 and the patient is asymptomatic or symptomatic, it's appropriate to replace the aorta. If there is a smaller aortic aneurysm of only 5 centimeters, but this bicuspid aortic valve, because of that abnormal flow dynamics, if there is a risk enhancer, for example, a family member with an aortic dissection, then often an earlier aortic replacement is recommended. If a smaller aneurysm is present and the bicuspid aortic valve is going to be replaced with surgery, then both could be operated on. And then these recommendations from the guidelines at the bottom here really talk about when to perform valve-sparing replacements or when to replace the aorta if you're not going to be operating on the valve. And in general, that's an individualized discussion, but really should be done at a comprehensive valve center. So in summary, I think that multimodality imaging is really instrumental in diagnosing the bicuspid aortic valve and to look for aortopathy. I think an echo is our standard first line for diagnosis, but don't be afraid to order other imaging to help diagnose both the aortopathy and the valvular pathology. And although genetics are a major cause here of the valve formation, I think flow dynamics often cause a lot of the aortopathy. So please think about that as you're reviewing your imaging. Thank you.